Sepsis and septic shock. Hello and welcome to Future MD Journey, where we simply demystify medical concepts. Today's topic of discussion is sepsis and septic shock. Let's begin by outlining our discussion. Definitions: pathophysiology, common identifiable microorganisms and sites of infection. Risk factors, clinical manifestations, investigations, and lastly, management principles. But first, why talk about sepsis and septic shock? Sepsis stands as one of the leading causes of morbidity and mortality worldwide. Timely diagnosis and management are crucial for the outcomes of patients with sepsis and septic shock. Now, let's delve into the definitions. Sepsis is a life-threatening organ failure caused by the host's dysregulated response to infection. Septic shock is defined as a subtype of sepsis, manifested by circulatory, cellular, or metabolic instability associated with a higher risk of death than sepsis itself. There is a fast scoring system that has been designed for rapid identification of patients at potential risk of sepsis, called Quick Sepsis-Related Organ Failure Assessment, QSOFA. The QSOFA criterion include at least two of the following. 1. Hypotension with systolic pressure less than 100 millimeters of mercury. 2. Tachypnea with a respiratory rate greater than 22 breaths per minute. 3. GCS less than 15. Now moving on to the pathophysiology of sepsis. Sepsis is multifaceted disruption of the finely tuned immunological balance of inflammation and anti-inflammation. There is firstly, local activation of inflammatory mediators. The inflammatory reaction is mediated by the release of cytokines, including tumor necrosis factor alpha, interleukins, and prostaglandins, from neutrophils and macrophages. Next is generalized endothelial dysfunction. The cytokine storm during hyperinflammation damages the endothelium, causing dysregulated vascular tone and impairing vascular permeability. The released cytokines activate the extrinsic coagulation cascade and inhibit fibrinolysis. Activation of the coagulation system leads to consumption of endogenous anticoagulants, e.g., protein C and antithrombin, which play a role in the development of microvascular thrombosis and disseminated intravascular coagulation. Lastly, the microcirculatory dysfunction leads to further loss of smooth muscle tone, reactivity, and peripheral vasodilation, ensuing organ hypoperfusion, impaired oxygen delivery to the tissues, and anaerobic glycolysis, which can contribute to the accumulation of lactic acid and metabolic acidosis. As previously discussed, sepsis represents a dysregulated host response to infection with a variety of identifiable microorganisms at its core, including gram-positive bacteria such as Staphylococcus aureus and Streptococcus pneumonia, gram-negative bacteria like Escherichia coli, Pseudomonas, and Klebsiella, as well as fungal infections such as Candida. Let's explore the common sites of infection related to sepsis. These encompass the respiratory tract or pulmonary parenchyma, the genitourinary system, the gastrointestinal system, and the head, often associated with fever of unknown origin. Risk factors for sepsis and the development of septic shock are extremes of age, encompassing neonates and elderly individuals over 65 years old, immunosuppression, as seen in conditions like HIV or cancer, prolonged hospitalization or stays in intensive care units, having chronic medical conditions such as kidney disease or cirrhosis, use of corticosteroids, presence of indwelling catheters or heart valves for extended periods, pregnancy or recent childbirth. Clinical manifestations of sepsis encompass a range of symptoms, including fast heart rate, fever or hypothermia, shaking or chills, warm, clammy, or sweaty skin, confusion or disorientation, hyperventilation, shortness of breath, cyanosis, oliguria or anuria. In children, symptoms may present as fast breathing, convulsions, pale skin, lethargy, difficulty waking up, feeling cold to the touch. Now moving on to the investigations. The investigations of sepsis, also called the septic workup, are primarily done to find the source of infection, to elicit diagnosis and to assess the prognosis of the sepsis. Laboratory investigations include full blood count with differential, basic metabolic panel, lactate, procalcitonin, and liver enzyme measurements, venous or arterial blood sampling to check acid-base abnormalities, coagulation studies, urinalysis, peripheral blood culture, culture of urine and stool for diarrhea and recent antibiotic use, sputum samples for respiratory symptoms, skin and soft tissue samples for skin abscess or ulceration. Cerebrospinal, joint, pleural, and peritoneal fluid cultures are obtained as clinically indicated. Imaging studies should include chest radiography, with additional studies as indicated such as echocardiography for suspected endocarditis, chest CT scan for empyema or parapneumonic effusion, CT abdomen or pelvis for renal or abdominal abscess. Moving on to the management principles of sepsis and septic shock, it's crucial to understand that these conditions require urgent intervention. Firstly, we initiate the initial evaluation of the patient using the ABCD approach, ensuring we assess their airway, breathing, circulation, and neurological status. Next, we establish intravenous access and continuously monitor the patient's cardiac function and oxygen levels. This helps us closely monitor their response to treatment. A septic workup is conducted, involving obtaining at least 2 sets of blood cultures and measuring serum lactate levels to identify the causative pathogen and assess the severity of the infection. Fluid resuscitation is initiated promptly by administering intravenous crystalloid solution at a rate of 30 milliliters per kilogram of body weight within the first 3 hours of presentation. Empirical antibiotic therapy is started immediately, targeting the suspected site of infection, likely pathogens, and local resistance patterns. Source control is essential, involving procedures such as removing infected tissue or catheters, and consulting surgery for acute abdomen cases. Vasopressor therapy may be required in cases of persistent hypotension to maintain a target mean arterial pressure of greater than 65 millimeters of mercury. Oxygen and ventilation support are provided as needed to optimize respiratory function. Supportive care is crucial for improving overall well-being and outcomes, including maintenance fluids, blood transfusions, electrolyte replacements, and glycemic control. Venous thromboembolism prophylaxis with low molecular weight heparin is considered unless contraindicated. Finally, identifying and treating complications such as acute kidney injury, disseminated intravascular coagulation, and acute respiratory distress syndrome are essential components of sepsis management.